Hi everyone. This recording will be on Chapter 22, the respiratory system. Respiration involves both the respiratory and the circulatory systems. It consists of the conduction zone and the respiratory zone. There are four processes that supply the body with oxygen and dispose of carbon dioxide. They are pulmonary ventilation, also known as breathing, external respiration, transport, and internal respiration. For pulmonary ventilation, this is the movement of air into and out of the lungs. For external respiration, this is the exchange of oxygen and carbon dioxide between the lungs and the blood. For transport, oxygen and carbon dioxide are transported in the blood. And for internal respiration, oxygen and carbon dioxide are exchanged between the systemic blood vessels and the tissues. And you can see that there's overlap between the respiratory system and the circulatory system, particularly at the second process of respiration, the external respiration, which is the exchange of oxygen and carbon dioxide between the lungs and the blood. The functional anatomy of the respiratory system include the major organs as follows. We have the nose, the nasal cavity, the nasal concha, and the paranasal sinuses. We have then the pharynx, the larynx, the trachea, the bronchi and their branches, the lungs, and alveoli. This illustration shows the major organs, starting with the nasal cavity. We see that the nostril is the entryway, and then the nasal cavity and the oral cavity come together in the throat, which is the pharynx. And you'll learn that the pharynx has several parts, the nasopharynx, the oropharynx. And then we enter into the larynx as part of our respiratory system. Notice that the respiratory system is an out pocket of the digestive system. It comes off of the esophagus anteriorly. So the larynx will be protected by the epiglottis, as you can see here, this flap that we'll talk about. So the larynx leads to the trachea, which then at the carina, which is the branch here of the trachea, it's going to branch into the right main or primary bronchus and the left main or primary bronchus. And then once we get into the left and right lungs, the bronchi will branch in a tree and end in the alveoli, where the exchange of oxygen and carbon dioxide take place. Notice the diaphragm is a skeletal muscle that is going to be the floor, if you would, of the thoracic cavity. It divides the thoracic cavity from the abdominopelvic cavity and has very important function in breathing. All right, so let's talk about the nose as part of that conduction system. The nose is the only external portion of the respiratory system. Air will enter through the nostrils, which contain two nasal cavities. Nasal concha within those cavities increase the surface area for moistening and warming inhaled air. Nasal cavities are lined by a mucous membrane, and odor receptors are located in the olfactory epithelium. Tears empty into the nasal cavities by way of the nasolacrimal canals. The paranasal sinuses connect to the nasal cavities and act as resonating chambers for speech. They are lined by a mucous membrane. The palate separates the oral cavity from the nasal cavity. The palate has hard palate and soft palate portions. That resonating for your speech is what causes your voice to sound lower to you than it does to others. This illustration shows the nasal cavity, and you can see the nasal concha, the superior, middle, and inferior nasal concha. We see also the nostrils, And remember, these are paired. There's a right nostril and cavity and a left nostril and cavity. We see the nasopharynx, in which we'll have the pharyngeal tonsil, the opening of the pharyngotympanic, or what we know of as the eustachian tube, uvula. And then we mentioned that the oropharynx, which is part of the throat, that pharynx, we've got nasopharynx, oropharynx. This is going to have the palatine tonsil and the isthmus of the fauces. This opening here. And then once we get into the larynx area, you can see that third part of the pharynx in that throat is the laryngopharynx. And this is that pivotal, pardon me, this is that pivotal part where we will be an out pocket off of the digestive system. So we see that the esophagus is dorsal or posterior to the larynx and the trachea. And so with the larynx, in order to protect it, we have the epiglottis, which will close during swallowing. We have the thyroid cartilage, which helps to hold the larynx open, the vocal cord, and the cricoid cartilage, which is going to be C-shaped. All right, so let's go over those three parts of the pharynx now. The pharynx or throat connects the nasal and oral cavities to the larynx. So the nasopharynx is the passageway for air, and it connects to the nasal cavities. And then the oropharynx will be the passageway for air and food, and it's connected to the oral cavity. And then that pivotal point where they both kind of converge on each other is the laryngopharynx, and that is connected to the trachea anteriorly and the esophagus posteriorly. Tonsils provide the primary lymphatic tissue defense for breathing. So again, here's our nasopharynx, our oropharynx, and our laryngopharynx. So the larynx is a cartilaginous passageway for air between the pharynx and trachea. It houses the vocal cords, which are mucosal folds that vibrate as air is expelled. Pitch is regulated by the tension on the vocal cords. Loudness depends on the amplitude of the vibrations. So it's one of the reasons also why men will have a deeper voice than women typically, simply because the vocal cords in men are going to be larger than women. All right, so the larynx continued. The glottis is the opening between the vocal cords, and the thyroid cartilage is the large cartilage that protects the larynx and vocal cords, and the epiglottis prevents food from entering the larynx. And you've seen the hyoid bone a couple of times already in this presentation. Remember, the hyoid bone is a movable base for the tongue. We see the thyroid cartilage here, and then the laryngeal prominence, also known as the Adam's apple. So again, that will be larger in men as a result of, testosterone, secondary sex characteristics, and that will provide the lower voice. Here's our cricoid cartilage and our tracheal cartilages. We see the epiglottis here, and you can see again the thyroid cartilage, the vocal fold, which will be the true vocal cord, and then we'll see that the glottis is that space in between. And again, we see our cricoid cartilage and our tracheal cartilage. That C-shaped cartilage is beautiful. It's a hyaline cartilage, and it holds the trachea open. And as you can see, it's lateral and anterior, so anterolateral, if you would, and then dorsal or posteriorly, the cartilages are not present there because of the esophagus. We need room for that esophagus to expand as you swallow. For voice production, speech is the intermittent release of expired air while opening and closing the glottis. Pitch is determined by the length and tension of the vocal cords. Loudness depends upon the force of air, like the amplitude as they go through the vocal cords. Chambers of the pharynx, oral, nasal, and sinus cavities amplify and enhance the sound quality. Sound is then shaped into language by muscles of the pharynx, the tongue, the soft palate, and the lips. And as you know, there are speech centers in the brain. There's the motor control center, that's Broca's area. And then, of course, we have the recognition speech in the Wernicke's area. For some reason, this just makes me want to go, oh. So we can see the epiglottis, and then the vestibular fold and the vocal fold. And the vocal fold is your true vocal cord. And as you are, opening the glottis and pushing air through the vocal cords, it's creating the sound that then is shaped by your mouth as it comes out as words and sounds. It's just so beautiful. All right, so now let's go to the trachea part of that conductive system. We're still in the anatomy. So the trachea connects the larynx to the primary bronchi. It is anterior to the esophagus. The fibroelastic membrane allows the trachea to expand, and those C-shaped cartilaginous rings prevent the trachea from collapsing and allow for expansion of the esophagus. So this is a beautiful view of that hyaline cartilage. You can see all those chondrocytes, if you would, that are in their lacuna. See how the little purple dots are their nuclei, and so they have formed that hyaline cartilage and will maintain that matrix throughout your life. Notice the cilia. This is pseudostratified ciliated columnar epithelium, and so it's going to secrete mucus and transport it so that we can get out of our bronchi, our lungs, our trachea. It gives us the mucus, and those cilia are going to move it upwards superiorly towards your mouth, well, the larynx area, I guess, and then you swallow that mucus without generally being aware of it, unless you have an overproduction. This is a very sensitive epithelium as well, which is wonderful because it is going to help to prevent asphyxiation and aspiration of foods and beverages. So let's look more at that pseudostratified ciliated columnar epithelium. This is your mucociliary escalator. So as mentioned, we're going to secrete that mucus and we're going to move it upwards. It's the escalator. It's going to move superiorly towards your larynx, where you will tend to just swallow it without being aware of it. The bronchial tree. This is going to occur when the tracheal divides into the right and left primary bronchi to enter the lungs. Again, the carina of the trachea is that branching point. It's very sensitive, and it will stimulate the cough response to expel solids and liquids. The primary bronchi branch into secondary bronchi, one for each lobe of the lungs. There are 3 for the right lung and 2 for the left lung. The secondary bronchi divide then into the tertiary bronchi. Moving along the pathway of air conduction, the bronchi get smaller and smaller. As they get smaller, they lose cartilage in the walls and gain smooth muscle. Bronchioles are the smallest conducting airways. There are no cartilages in there, and each bronchiole leads to those beautiful air sacs called alveoli. Look at that tree. So what a tree pattern does is it increases surface area. So when you look at a tree out in nature, you can see that it has the trunk and then it has all of the branches. And at the tip of those branches will be the leaves, which are the photosynthetic organs of that plant. They are organs. They contain tissues that perform functions. And so in this case, this is the organs that does the respiration for us, just like the leaves do the respiration for the trees. And it's the same gases that are being brought in and out. It's just in the opposite. So with humans, we're breathing in oxygen for our cellular respiration, and we're breathing out carbon dioxide. For the trees in nature, they are breathing in carbon dioxide because they use that carbon dioxide to make their ATP, which their sugars, excuse me, that will then go and formulate their ATP for cellular respiration. And then they breathe out oxygen as a waste product of that. So it's an exchange between us and them, both using this tree-like branching system to increase the surface area for respiration. So as you're learning these features of anatomy, they spread across different species and totally different phyla, and even kingdoms, the plant kingdom, the animal kingdom, etc. And so that's one of the exciting things about biology is these patterns in nature are for a reason and they repeat. You may have seen this in the nervous system. It's the same thing. When the spinal cord branches into the rami, which mean branch, they then branch into smaller units known as our nerves, and then the nerves with their motor units go out and connect to all the effectors and the receptors that are in our body, and it makes this tree-like pattern because it increases the surface area. So as you can see, we've got the primary bronchi, secondary bronchi, tertiary bronchi, and then if you would, the little leaves of our lung trees are going to be the alveoli. So here's another view of that tree, and this is from an actual lung. So you can't really deny that it absolutely has that branching pattern. And we learned that the right lung has three segments, or three lobes, if you would. We can go back here, three lobes. And then the left lung has two. And you may have already guessed it's because of the notch for our heart. Our heart sits towards the left lung in the majority of individuals. All right, so let's look at our leaves, the alveoli, if you would. So these are the sites of gas exchange. And so they are made up of simple squamous epithelium, and they are surrounded by the pulmonary capillaries. So we're going to learn that the deoxygenated blood is going to come into the lungs from the right side of the heart, and those pulmonary arteries will carry the deoxygenated blood to these capillaries. And then these are going to be the sites where we will then breathe out the carbon dioxide and we will breathe in the oxygen, reoxygenating our blood. So here's where the magic happens. So we can see that the smooth muscle, remember, we start losing our cartilage. And we're also going to learn that one of the reasons that, we increase our smooth muscle, we decrease our cartilage, and we narrow our airways is to slow that passageway of air down. Because we want, when it hits the alveoli, to basically be static so that we can really get the maximum amount of gas exchange. So we want maximum amount of oxygen coming into our bloodstream, and we want the maximum amount of carbon dioxide to exit. And of course, there's limits for that because we have a homeostasis that we must maintain. And we don't even use all the oxygen that we breathe in, believe it or not. We only use, gosh, I think it's like 25% a quarter, something like that. So here's a scanning electron micrograph of casts of the alveoli and their associated pulmonary cavities. So you might be wondering, well, how do plants do it? They don't have the capillaries all over them. Plants have little pores called stomata, and they open those pores, and that is what's going to bring in the carbon dioxide and expel the oxygen. So they do have vascular tissue. They have xylem and phloem, and they have photosynthetic pigments that are right there in the leaves, that what makes them green, right? And they are going to go ahead and capture those oxygen and carbon dioxide molecules and those electrons from the sun and initiate photosynthesis there and then. And so what we have to do is we have to bring that oxygen and carbon dioxide, inwards. And so that's why we have the capillary system on the inside around our alveoli versus the breathing pores right then and there all over the leaves of the trees. There you go. So now you'll look at them a little bit differently, won't you? Neat stuff. And that's why I love biology. I love this overlap between the kingdoms. Nature is gorgeous in its design. But I digress. Let's talk about how alveoli stay open. Remember how I said those stomata have to open to let that pore let the gas exchanged in that pores. So our alveoli have to remain open as well. So there is a surfactant that we have that lowers the surface tension of water lining the alveoli. and that prevents them from collapsing completely because surface area or surface tension of water will cause those alveoli to stick to each other. And so there are cells called alveolar type 2 cells that secrete that surfactant. Respiratory distress syndrome can occur in premature infants who lack surfactant. So my mother was born premature to the point where her lungs weren't fully developed. So she was in NICU and had to be in the chamber for helping her to breathe during that very, very pivotal time of her development because she underwent respiratory distress syndrome. So that alveoli also contain dust cells, which are macrophages that defend against inhaled debris and pathogens. So the respiratory membrane of the alveoli will facilitate rapid gas exchange. It is composed of the alveolar epithelium and capillary epithelium and their fused basement membrane. And so these are both simple squamous epithelia. And so that's going to maximize diffusion because they are extremely thin and they have a very large surface area. All right, so here we can see an artistic representation of each alveoli here, and you can see the alveolar membrane and how the respiratory membrane, if you would, and how it is the simple squamous epithelium of the alveoli and the simple squamous epithelium of the capillaries. And then you can see the basement membrane in between that is fusing all of those together. And so then we see the other cells in there. We've got the dust cells, where there we go, macrophage in blue. We see that. That's the macrophage. And then the green will be the type 2 surfactant secreting cells that will basically kind of secrete a soap, if you would, because that's how soap works. Soap is going to decrease the surface tension of water so it doesn't beat up on your skin, and that helps to carry dirt and debris away from your skin. All right, so now to the lungs. So the lungs are paired cone-shaped organs with lobes. The apex is at the superior end. The base is on the diaphragm. So remember, apex, like the apical surface, is the top or superior layer. The basement, is the bottom or inferior layer. The right lung has 3 lobes and the left lung has 2 lobes. And each lobe is divided into lobules or lobules. Each lobule has a bronchial and pulmonary artery that serve many alveoli. The cardiac notch occurs on the left lung and allows room for the heart within the thoracic cavity. The lungs are going to be surrounded by a double-layered serous membrane called the pleura. The visceral pleura will adhere to the surface of the lung, and the parietal pleura will line the inside of the thoracic cavity. This produces a lubricating serous fluid that also creates surface tension between the layers to hold them together. So in this case, we want to facilitate surface tension. All right, so here we can see the right lung with the right superior lobe, right middle lobe, right inferior lobe. With the left lung, we see the left superior lobe and the left inferior lobe, and then the diaphragm making the base there. And you can see the apex of the lungs up there at the top. You can imagine your clavicles and like your first ribs being right there. Oh, and we're also looking at the pleura. We can see up here where it highlights, there's your rib. We can see that the parietal pleura is going to be on the body cavity wall, and then the visceral pleura is going to be on the organ. Remember, organ and viscera are synonymous. And there's a space in between that is going to have the serous fluid. And in this case, the serous fluid is going to increase surface tension to stick the lungs to the body cavity wall, which is going to be very important in facilitating respiratory process of internal and external, or this will be the external inhalation and exhalation. So let's move to that. This is going to be the mechanics of breathing. All right, so pulmonary ventilation consists of two phases. We have inspiration or inhalation, where gases flow into the lungs, and we have expiration or exhalation, where gases exit the lungs. It is a mechanical process that depends on volume changes in the thoracic cavity. Volume changes lead to pressure changes, and pressure changes are going to lead to gases flowing to equalize those pressures. Inspiration is an active process. Inspiratory muscles contract, which will be the diaphragm and the external intercostal muscles. Those are the muscles in your rib cage. The thoracic volume will thus increase, the lungs are stretched, and intrapulmonary volume increases. The intrapulmonary pressure will drop to -1 millimeter of mercury. That's the measurement for pressure. And air will flow into the lungs down its pressure gradient until the intrapulmonary pressure equals the atmospheric pressure. In this illustration, we see the sequence of events. We can see that inspiratory muscles contract, which is the diaphragm descends and the rib cage rises. The thoracic cavity volume will then increase, the lungs will be stretched, and the intrapulmonary volume will increase. The intrapulmonary pressure will drop to -1 millimeter of mercury, and the air gases will flow into the lungs down its pressure gradient until intrapulmonary pressure is 0. So it is equal then to atmospheric pressure. So we can see in the middle column of this table that changes in the anterior, posterior, and superior, inferior dimensions. So ribs are elevated and the sternum will flare as the external intercostals contract. And the diaphragm will move inferiorly during contraction. And then we can see the changes, we can see the changes in the lateral. Let me get back to it, my apologies. The changes in the lateral dimensions, we can see that the external intercostals will relax. And so as we are inspiring, we can see that we are kind of like elongating our chest. All right, so airway resistance. Airway resistance increases as the airways narrow. We mentioned that earlier. So as the airway resistance rises, breathing movements become more strenuous. Severely constricting or obstruction of the bronchioles can prevent life-sustaining ventilation, and it can occur during acute asthma attacks and stop ventilation. Epinephrine will dilate the bronchioles and reduce air resistance. That's what an EpiPen is for. And an inhalator. All right, so for respiratory volumes, there are 4 types of respiratory volumes. There's tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. So let's talk about those. Tidal volume is the amount of air moving in and out of the lungs during normal, relaxed breathing. It's about 500 milliliters per breath. The vital capacity is the maximum volume of air that can be inhaled plus the maximum volume of air that can be exhaled in one breath. It depends on 2 volumes, the inspiratory reserve volume and the expiratory reserve volume. The inspiratory reserve volume is forced inspiration, the volume of air inspired beyond the tidal volume. It's about 2,900 milliliters. Let's go back and take a look at that tidal volume again. The tidal volume is the amount of air moving in and out of the lungs during normal, relaxed breathing, and is about 500 milliliters per breath. So, just to give you the appreciation of that inspiratory reserve volume, we can get it up to 2,900 milliliters from 500. It's incredible. So then expiratory reserve volume is forced expiration. It's the volume of air expired beyond the tidal volume, and it's about 1,400 milliliters. So notice that there's going to be a residual volume because we're going to inhale a greater volume than we're going to exhale. So that's going to be the residual volume. It's the amount of air remaining in the lungs after a forced expiration. So it equals to about 1,000 milliliters. And this is important because it prevents the alveoli from collapsing. There is dead air space, so 30% of the inspired air that does not reach the alveoli for exchange but remains in the passageways. All right, so those were the 4 types of respiratory volumes: the tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. I've always been pretty proud of mine because as a swimmer, we have to really be able to inhale, hold our breath, and then exhale. So I've gotten a great tidal volume going on in the past, and I still think it's pretty good after all these years. I've started back swimming again. I do every summer. I go back to the pool and swim laps, and still hanging in there, doing real well. So what measures that is the spirometer. So that is an instrument that records the volume of air exchanged during breathing. And the spirogram shows the measurements recorded by a spirometer. So here we can see the tidal volume here in the center, and then we have the inspiratory reserve volume, the expiratory reserve volume, the residual volume. And we can see that we are measuring that volume of the air in the lungs per milliliter over the number of breaths over the number of time. So the higher that is, of course, the healthier your lungs, if you would, the more air you can hold, your inhalation, and then the more air you can exhale during your exhalation. All right, so ventilation is controlled by a primary respiratory center in the medulla oblongata. Signals will come from here and cause the contraction of the respiratory muscles. So we have the phrenic nerve that carries impulses to the diaphragm from your cervical plexus. We have the intercostal nerves, which will come from the rama of your thoracic spinal cord that will stimulate the external intercostal muscles. And then we have the normal breathing rhythm called eupnea. Eup means true. And that also requires input from your pons. So if you remember from the nervous system, the brainstem is the midbrain pons, medulla oblongata. And so the pons has breathing centers for pneumotaxis, which is the inhalation and exhalation of your lungs. So here we see the respiratory control centers in the pons there. There's your pons. It's kind of got this expanded belly. And then we see the medulla oblongata, which is then going to merge into the spinal cord. And so we see the cervical plexus, and we've got the phrenic nerves arising from the cervical plexus, and they come to the diaphragm. And then we see these beautiful external intercostal muscles coming from the thoracic branches of the spinal cord. For the control of ventilation, we've got nervous input, which can influence the depth and rate of breathing. So we just talked about the brain centers, and then now let's take a look at those nervous input a little more detail. So we've got the cerebral cortex, the limbic system, the hypothalamus, and even other brain centers. So hyperpnea is higher than normal breathing rate. And then the Herring-Brauer reflex prevents overinflation of the lungs. Other controls of ventilation include chemical input. So the respiratory center is sensitive to the levels of carbon dioxide and hydrogen ions in the blood. This is so true. The medulla oblongata, in particular, is sensitive to the carbon dioxide. And so when the carbon dioxide and the hydrogen ions rise, breathing rate and depth is increased because we need to get the carbon dioxide out so we don't become acidotic. We have peripheral chemoreceptors that are sensitive to the level of oxygen in the blood. And so when oxygen levels fall, the breathing rate and blood pressure is increased because we need to bring in extra oxygen. And then pardon the pronunciation, but the Shine-Stokes respiration is a condition where chemical input is the main control over respiration. All right, so let's talk about that physiology. So we just talked about the anatomy of the respiratory system. Then we talked about like the mechanics of breathing. So that, of course, got into some of the physiology because it's starting to be the function. Now we're going to go deep into the physiology with gas exchange and transport. All right, so respiration includes both the exchange of gases in the lungs and in the tissues. So concentrations of oxygen and carbon dioxide dictate the direction of movement, either in or out of the blood. External respiration is the exchange of gases in the lungs between the air in the alveoli and the blood in the pulmonary capillaries. And of course, it includes oxygen and carbon dioxide. Oxygen will have a higher concentration in the alveoli as you breathe in, and it diffuses from the alveoli into the blood. Carbon dioxide, on the other hand, will have a higher concentration in the blood, and it will thus diffuse from the blood into the pulmonary capillaries to the alveoli. Because remember, we have a concentration gradient where we diffuse from a higher concentration to a lower concentration. So there's a partial pressure that is involved in this, and that is going to be the amount of pressure exerted by each gas. It is symbolized as P with a subscript O2 for partial oxygen and a P with a subscript of CO2 for partial carbon dioxide pressure. So alveoli partial oxygen pressure is higher than in the blood. So that's what we just talked about before. So the oxygen is higher in the alveoli. And then the blood carbon dioxide is higher than it is in the alveoli. So carbon dioxide is higher in the blood. So oxygen will be higher in the alveoli. Carbon dioxide will be higher in the blood. All right, internal respiration is the exchange of gases in the tissues between the blood and systemic capillaries and tissue fluid. So oxygen will at this time then have a higher concentration in the blood once we get to our tissues. Thus, it will diffuse from the blood into the tissue fluid, and the partial oxygen then of the blood will be higher than in the tissue fluid. So we are going to, of course, diffuse that oxygen from the higher levels in the alveoli into the blood. So that's when we reoxygenate our blood. Then our blood is going to go to our tissues. And at this point, our reoxygenated blood is going to be higher than what we have in our tissue fluid, our interstitial fluid. And that's what's going to push that oxygen out of the capillaries and into your tissues. And then, of course, it will be replaced by carbon dioxide. So once we have lost the carbon dioxide, or built up carbon dioxide as a product of our waste of cellular respiration, it will accumulate in our tissue fluid. And so then we're going to push it into our blood. And then, of course, we're going to take it back up to our lungs. And so by this point, that's why once we get to our lungs, the carbon dioxide levels will be higher in our blood. And then that will push that out of the alveoli and we'll breathe that out. Ta-da! So here's the table that illustrates this very nicely. So we see that once we leave the right side of the heart and we go into pulmonary circulation, we are going to have a higher level of carbon dioxide, a higher partial pressure of carbon dioxide in our blood, and that's going to cause it to diffuse into our alveoli, and then we're going to breathe it out. And so then when we inspire our air and we breathe in the oxygen, we're going to have more of the oxygen in our alveoli, which is then going to diffuse it into our bloodstream. Then we're going to travel back to the left side of the heart and we're going to pump it out into our systemic circulation, which is going to go to our body tissues. And once we're in our tissue fluid, you can see that the higher levels of oxygen are going to then diffuse into our tissue fluid because at this point the tissue fluid will be higher in carbon dioxide because our cells are undergoing respiration, cellular respiration, and they're going to use that oxygen for cellular respiration, and the waste product from that is carbon dioxide. And then that will go back into our bloodstream in our systemic circulation up towards the right side of our brain where it will then heart where it will then enter back into the pulmonary circulation. And it will do that all day, every day for the course of your life. All right, so how are we transporting all those gases through the bloodstream? Well, we're doing it through hemoglobin. So 97 to 98% of oxygen is transported by hemoglobin in our red blood cells. It is the iron, which is the heme portion of hemoglobin. Globin means like it's a globular protein, it's a circular globe shaped sphere. And the heme is going to refer to the iron in the center, and that's what's going to bind to the oxygen. So oxyhemoglobin will be a scarlet red color because that will be when the hemoglobin is combined with your oxygen. That's what our arterial blood will look like. And then our venous blood will have deoxyhemoglobin, which is going to be hemoglobin without oxygen, and that's why when you get a blood draw from a vein, it's that deep red color. So a very small amount of the oxygen will be transported in the plasma, only about 2 to 3%. All right, believe it or not, carbon dioxide is also going to be transported through the body via hemoglobin, but it's not going to connect to the heme portion, it's going to connect to the globulin portion. So it's called carbaminohemoglobin. And so that carbaminohemoglobin is going to be about 30% of the carbon dioxide that's transported, and the other 10% will be in the blood plasma and in the cytoplasm of red blood cells. Carbaminohemoglobin. I think that's my new favorite word for the day. Carbaminohemoglobin. All right, so let's say some more fun words. All right, so most of the carbon dioxide is transported in bicarbonate ions, so about 60%. So you might have been wondering, where's the other 60% if only 40% is transported in the red blood cells? And so bicarbonate ion is your answer to that. So carbon dioxide, which is CO2, will combine with water, which is H2O, to form carbonic acid in the red blood cells. So carbonic acid dissociates into the hydrogen ions and the bicarbonate ions, and the enzyme carbonic anhydrase catalyzes this reaction. So this is an important aspect of transport because it influences the pH of your blood and tissue fluid. So excess hydrogen ions will combine with the globin portion of hemoglobin, and that is called a reduced hemoglobin. And then bicarbonate ions will diffuse out of the red blood cells into the plasma in exchange for chloride ions. And we call this the chloride shift. All right, so here's the respiratory system helping to regulate pH. So the bicarbonate carbonic acid buffer system is altered by breathing. Hypoventilation and hyperventilation both have an effect on pH. So hypoventilation is decreased breathing levels, right? And so that's going to lead to an increase in carbon dioxide because we're not able to breathe that out. What that's going to do is that's going to decrease our pH and can lead to acidosis if our pH becomes less than 7.35. Hyperventilation will increase our respiration rate, and that will increase our pH, and that is going to result if in alkalosis if the pH is greater than 7.45. So remember your homeostatic range of pH. It's 7.35 to 7.45. One thing that you might come in contact with clinically is patients that suffer from COPD, or chronic obstructive pulmonary disease. This is exemplified by chronic bronchitis and emphysema. It is an irreversible decrease in the ability to force air out of the lungs. So remember that forced inhalation, forced exhalation, that 2,900 milliliters coming in, that 1,400 milliliters going out, right? And so this is going to affect that. And it's irreversible. So other common features are going to be a history of smoking in 80% of the patients, dyspnea, which is labored breathing, coughing, and frequent pulmonary infections, and most victims develop respiratory failure, and that is going to be hypoventilation accompanied by respiratory acidosis. Asthma is characterized by coughing, dyspnea, wheezing, and chest tightness. It is the active inflammation of the airways that precedes bronchospasm. Airway inflammation is an immune response caused by the release of interleukins, the production of IgE, immunoglobulin E, and the recruitment of inflammatory cells. The airways are thickened with inflammatory exudate, and that magnifies the effect of bronchospasms. And exudate would be like mucus. All right, so we also have tuberculosis as far as our homeostatic. So we talked about COPD, asthma, now tuberculosis. So this is an infectious disease caused by a bacteria, and that bacteria is called Mycobacterium tuberculosis. Symptoms will include fever, night sweats, weight loss, a racking cough, and spitting up blood. So treatment is going to entail a 12-month course of antibiotics. For stress relief, just take a deep breath. Start the week calm with 4 deep breathing techniques. We've got belly breathing. Slowly fill and empty your belly with breath. Breath count. Count your breath slowly and evenly. Mindful breathing. Pay attention to the rhythms of your breath. And breathing visualization. Visualize taking in something positive with each breath. That sounds good to me. Thank you so much for listening.